So I am walking into my patient's room. I am going to perform hand hygiene for 20 seconds, and then I am going to close my patient's curtain to ensure privacy. So now I will introduce myself to my patient. Hi, my name is Amanda. I will be your nurse today. And what is your name?
Molly.
Perfect. Hi, Molly. And do you know where you are today?
The hospital.
And do you know the year?
2020.
Perfect. Can you give my hand a shake? There you go. So my patient is alert, awake, and oriented ×3 because her eyes spontaneously moved when I walked into the room. She was able to follow motor commands by shaking my hand, and her speech was appropriate when I asked the question, so she gets a score of 15 on the Glasgow Coma scale. Now moving right along, we are going to ask our patient why they're in the hospital today. So what brings you in?
Blurry vision.
Okay, and when did the blurry vision start?
Last night.
And can you describe the blurry vision? Is it cloudy? Is it spotty?
Cloudy.
Perfect. And did you hit your head at the onset? Do you have a headache that accompanies it?
Nope.
And how does this influence your daily activities?
I can't read the newspaper.
Okay, so are there any allergies that I should know about?
Nope.
Do you have any past medical history?
Nope.
And do you take any medications at home?
Nope.
All right, so moving right along, we are going to then assess for our patient's vital signs. So our first step is going to be taking the blood pressure. So I will do this by doing the two-step method. So I will place the blood pressure cuff around the upper arm, noting where the brachial artery is and placing the arrow directly above that. Then I will feel for my patient's radial pulse, and I will pump up the cuff until I no longer feel the radial pulse present and note that number. So it is 100. So then I will take my stethoscope, I will place it in my ear and put the diaphragm of the stethoscope over my patient's brachial artery, and then I will pump up the blood pressure cuff until it is 20 to 30 millimeters over the 100 that I first noted. So that is the place where the radial pulse had stopped. So I'm going to pump it up, and then I'm going to slowly loosen the bulb on the blood pressure cuff, and the first sound that I hear will be the systolic, and then when that sound disappears, I will note that number as the diastolic. So the normal finding is that it's 120/80 or 90/60, so that is good. And I will take the blood pressure cuff off, and then I will assess for my patient's radial pulse for 1 minute, and the normal finding is that it is 60 to 100 beats per minute. And then I will place my patient's hand over their chest and count for 1 inspiration and 1 expiration as 1 breath, and the normal finding is 12 to 20 breaths per minute. And then I will take a temperature of my patient by sticking a probe underneath their tongue, and then the normal finding is that her temperature should be from 96.4 to 99.1, and then I will take my patient's finger and place the oxygen, the pulse ox on my patient's finger, and the normal finding is that it is equal to 95% or greater, and then I will assess for my patient's skin. So I've noticed that her color is congruent with her ethnicity, and I am also going to take her finger to check for circulation and press down on the fingernail bed, and notice that the capillary refill is within 2 to 3 seconds, so that is a normal finding, and that her circulation is good. So the next thing I'm going to do is locate where my patient has pulses on her body. So we notice that the temporal pulse is right here. Then we have the carotid pulse, which is on either side of the trachea, and you want to feel for it on one side to not occlude the oxygen. Then we have the apical pulse, which is right over here, located underneath the breast. And then we have the brachial pulse, which is right here. Then we have the radial pulse, the femoral pulse, which is right in between the leg and the groin, the popliteal pulse, which is right behind the knee. Then on the medial side of the leg, we have the posterior tibial, and on top of the foot, in between the big and the first toe, you have the pedal pulse. Now pulses are graded on a scale of 0 to 3. So 3 means a 0 means no pulse. So you would have to confirm that with a medical provider. A +1 is a weak pulse, and a +2 is a normal pulse, and a +3 is finally a bounding pulse. So now moving right along, we are going to ask my patient to please stand up, and I will tell my patient that I am going to be coming from behind and assessing her thyroid gland. So I'm going to move her hair and feel along the trachea on either side, and noting that the right side is slightly larger than the left, but other than that we should feel nothing, so that is a normal finding. Then we will have my patient please take a seat, and we're going to assess for all the lymph nodes located on the body. And the lymph nodes should be painless, non-tender, and slightly movable. So we're going to first start with assessing the preocular, which is right by the ear, then the postocular is right behind the earlobe, right by the bone, and then along the hairline we have the occipital lymph node, and then we have the submental, which is right underneath the chin, and a little further back we have the submandibular, and then a little further back than there, kind of by the pointy part of the jaw, we have the jugulogastric, and then we have this superficial cervical, which is on either side of the trachea, located here, and then if you push down a little bit harder on both sides, you will feel the deep lymph nodes, and then the posterior cervical is right behind the neck along the spine. So that's where that is located. And then we have the subclavicular, which we will have our patient hunch a little bit forward, and we will feel inside the notch and make sure that we don't feel anything. And then the axillary is in the armpit, and then the epitrochlear is located at the crease of the elbow, and then finally we have the inguinal, which is right along the groin. So next we will test for the cranial nerves. So the first cranial nerve is sensory, and that is called the olfactory. So to test this, we're going to have our patient occlude one side and breathe in and out, and then do the same thing on the other to test the patency. So she can do that. So we're going to test this by having our patient close our eyes and then occlude one side and identify a familiar scent.
Coffee.
Perfect, which she does with ease, so that is a normal finding. And then we are going to test cranial nerve number 2, which is our optic. And this is sensory. So in order to do this, I'm going to have my patient then cover her left eye, and I will cover my right, and we are going to test for her peripheral vision. So I'm going to raise my hand and wiggle my fingers, and she's going to tell me when she sees them.
No. 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 No.
Perfect, which she is able to do. Next, we are going to test for cranial nerves 3, 4, and 6. And now we test these together, and the first one is the third cranial nerve is the ocular motor, and then we have the trochlear, and then we have the abducens. And in order to test these, which is all motor, we are going to test for Perla. So in order to do this, I'm going to take my pen light, and I'm going to have my patient look into the distance. So I'm going to have her look at that lamp, and we're going to make sure that her eyes dilate. And then we are going to come across with my pen light, and I'm going to shine it in the first eye, coming across to the second, and on this side, so the first eye that I shine my light into, the pupil should constrict, and then I'm checking for consensual constriction on the other side. Then I will check for accommodation. So I will have my patient look at the pen light, and her eyes should constrict and converge as I come forward, which is a normal finding, so she passes with ease. Next, we are going to do the trigeminal nerve, cranial nerve, which is number 5, and this is both sensory and motor. So in order to do this, we are going to take our cotton whisk, and we are going to have our patient notice that this is what it feels like. So we're going to take this cotton whisk and strike it on the forehead, the cheek, and the chin. Then I'm going to have my patient close her eyes, and on one side of the face, I'm going to have her point to when she feels that I strike her face with the cotton whisk. So can you point? Perfect, which she is able to do, so she passes. And now we are going to test for cranial nerve number 7, which is facial. And the facial cranial nerve is both sensory and motor. So in order to test this, I'm going to have my patient smile, frown, and puff out her cheeks, noticing that it is symmetric on both sides and equal, so she passes. Next, we are going to test for the acoustic cranial nerve number 8, which is sensory. So I'm going to have my patient stand up, and I'm going to have her occlude her left tragus, holding it up and down, and then I'm going to whisper 3 two-syllable words in her ear. And she's going to repeat them and identify, and if she's able to do that, then she passes with ease. So, football,
Football.
soccer,
Soccer.
pony,
Pony.
which she is able to do. So she passes, and now we are going to check for cranial nerves 9 and 10. So 9 is the glossopharyngeal, and then 10 is the vagus. So I'm going to have my patient stick out her tongue and say, ah, and I'm going to notice that the uvula is midline and centered, and that the soft palate rises. And this is both sensory and motor. So she passes with ease. Now we're going to test the cranial nerve number 11, which is your accessory spinal. So I'm going to have my patient shrug her shoulders, look left and right, and then I'm going to apply resistance. So raise your shoulders, push against my hand, which she is able to do. So she's able to move her body against my resistance, so she passes. Next, we're going to test cranial nerve number 12, and this is your hypoglossal cranial nerve 12, which is motor. So I'm going to have her stick out her tongue and notice that it has no tremors, which is a normal finding. Moving right along, we are going to test for the cerebellar function. So I'm going to have my patient walk from point A to point B, which is about 20 feet. And as she walks, I'm going to notice that it's coordinated, there's no sidestepping, and that she's able to do it with ease, which she passes. Next, I'm going to have the Romberg test. So I'm going to have my patient stand with her arms at her side, close her eyes, and maintain her balance, and put my hands in the front and behind just in case she sidesteps. And a normal finding is that she's able to do this without sidestepping, which she does, so she passes. Next, we are going to test for the sensory portion of the cerebellar functions test. So I'm going to have my patient sit down. I'm going to have her roll up her sleeve, and we are going to do the sharp dull test. So I'm going to tell my patient that this is the sharp side, and this is the dull side. If we were in the clinical setting, I would break a tongue depressor in half and use that, but today we're using a fork. So I'm going to have my patient close her eyes. Now, please identify what side this is.
Sharp. Dull.
Perfect, which she does. And next, we are going to do the kinesthesia test. So I'm going to take her hand in mine, and I'm going to tell her that this is up and this is down. And then I'm going to have my patient close her eyes, and she's going to tell me which direction I'm moving her finger in.
Up. Down. Up.
Which she's able to do, so that is a normal finding. Then we are going to do the stereognosis test, and this test, I'm going to take a familiar object and place it in my patient's hand, and she is going to identify it.
A cotton whisk.
And she is able to do that with ease. So that was great, and that is a normal finding. Then we are going to do the graphesthesia test. So I'm going to take my patient's palm in mine. I'm going to tell her to please close her eyes, and I'm going to draw a familiar letter or number in her hand, and she's going to tell me what it is.
A.
And she does it with ease. She can do it. Next, we are going to do the deep tendon reflexes. So I'm going to have my patient roll up her sleeve because we are going to do the brachioradialis. So I'm going to take my patient's hand in mine, and I'm going to feel for the brachial tendon, and then with my thumb on it, I'm going to take the reflex hammer, and with the pointy side of the reflex hammer, I'm going to strike my thumb, and a normal finding is that the hand will supinate. Next, I will test for the triceps. So I'll have my patient bend her arm and take her arm in mine and let it go limp, and then I will feel for the triceps tendon, and with the sharp side of my reflex hammer, I will strike it, and the normal finding is that the arm will extend out. And then I will do the biceps tendon reflex, so I'll take my patient's arm in my own, and I will place my thumb over the crease of the elbow, and I will strike my thumb with the pointy side of the reflex hammer, and the normal finding is that the muscle will flex, which it does, so that's great. Next, we're going to test for the patellar reflex. So since her legs aren't dangling, I'm going to have her cross one leg over the other, and I'm going to have her perform an isometric exercise to distract. And then I'm going to feel for the patellar tendon, and I'm going to strike it with the dull side of the reflex hammer, and the normal finding is that the lower leg extends. To test the Achilles tendon reflex, I'm going to have my patient stand up and place one knee on the exam table. I am going to feel for the Achilles tendon and strike it with the dull side of the reflex hammer, and a normal finding is that you have plantar flexion. Next, we are going to test for the Babinski reflex. So if we were doing this in the clinical setting, I would have my patient's sole of the foot, and I would draw an upside down J, but I'm going to demonstrate with my hand. So a normal finding in an adult is that the toes will curl, and in an infant who hasn't walked yet, the toes will fan out. So that would be a normal finding. And then for the optometroscope, we are going to shine a light in my patient's ear canal, and we are going to examine the tympanic membrane, and a normal finding is that it is curly and gray and intact, and you don't want to have any scarring. And you want to notice the cone of light is at 7 o'clock in the left and 5 o'clock in the right. And that concludes our exam.